So we're talking about we're going to talk about now the four techniques that we use to interrupt sedation or wean sedation. So let me ask you this. Number one, we're going to do this based on the zero pharmacokinetics, the three-compartment model, and also the context-sensitive half-life. So let me ask you this. Imagine if you're in a plane, right? And you take the plane from here to New York, for example. Just want to. Okay. So you go on the plane. They said, "Oh, we don't have coach. We're gonna give you like upgrade you to first class, right? They put you first class. They massage the hell out of you. They give you wine. They give you foot massage, everything you want, right? But then the pilot above JFK says, "Oops, I forgot to decrease my altitude, or I decreased it to 20,000 feet. I can't land in JFK. I'm gonna land in Raleigh, North Carolina." What are you gonna? You're gonna write a thank you letter to the airliner, or are you gonna just be complaining about it?
I'd rather go to Raleigh.
Well, that's a different story. So yes, of course, that's what we do on sedation all the time. Is that basically you've heard this sign out before? Mrs. So and so is ready to be extubated, but we're just waiting for her to wake up. That is malpractice. You can't do that. There's nothing called I'm waiting for her to wake up. That means you concentrated on everything else. We like to concentrate on the sexy stuff, right? The balloon pump, the septic shock protocol, whatever, all of the things that we feel like we're doing something, but the sedation, we just leave it for everybody else. It's easy stuff. It's not easy. Yeah. Okay. So basically, the first thing that came out of this, and you see this on the order set, by the way. First thing is sedation holiday, or SAT, spontaneous awakening trial, or sedation holiday. Some people call it sedation vacation. Whatever you want to call it. But this is where you stop the sedation and let the patient wake up and then see what happens, right? So I was there before sedation holiday. I was a resident before sedation holiday. Came in towards the end of my residency, and all of my attendings made fun of it, and all of them rejected it. And I came up as a young fellow, young attending, and I also was against this sedation holiday. I was like, this is for people who don't know how to manage sedation, right? And in fact, one of my first attempts at protocols is that I said, if you have a BIS monitor, you don't need to have sedation. You don't need to do a sedation holiday, which I found that is wrong, because what happened is that I saw it myself. It's like you put the BIS monitor on somebody, and you make sure that it's always between 40 and 60, so you never overdose the patient. But then when you stop the sedation, it's still between 40 to 60 for 2-3 days after. So what is happening is like something is this internal pump or something of sedation that is going inside the patient, right? So obviously now I'm a big believer in sedation. I've been a big believer for 15 years now of sedation holiday, right? So there's no debate about this, right? So why did people, and until now, by the way, people, nobody dares say, I don't like sedation holiday, because you'd be against every single, a lot of literature. But I can tell you there's a lot of people that are not doing it. They're not doing it correctly, and they're not doing it completely because they're afraid of it, right? So let's say a patient is 10 milligram of Versed. So he's equilibrating now, 10 milligram, let's say whatever unit is, but 10, unit of 10, right? And then I stop this and make this 0. Of course, the brain is not going to go to 0 immediately. It's going to seep from here, internal infusion is going to be like 9 to 9, and then 8, 4, 8. And of course, the liver is here, is taking the Versed, so it keeps on sucking the 4, and then 7, 7, and then 0, 0, 0. When it's 0, 0, 0, what happened? The patient goes into rapid AFib, he bites his tongue, he pulls his central line, he beats the nurse, he does all of these things, very, very agitated. And the nurse will beg you, please put this monster to sleep. So you give him 10 milligram of Versed and put him on 15. So what did we gain? We were 10 milligram and now we're on 15, and the central line is half out, and everything is worse, right? But right now I learned that I'd rather be on 15 milligram of Versed an hour after a sedation holiday than 10 milligram an hour of Versed with equilibration. Because the 15 milligram an hour, what is going to happen is going to immediately, or within 10 minutes, it's going to equilibrate with the brain. But then it's going to take a whole day to show up in the fat, but I'm not going to let it, because tomorrow I'm doing another sedation holiday, right? So I'm always cutting the fat and not allowing it to go to the fat and allowing it between these two compartments only, so I avoid the big fat surprise, right? So that's the whole point. It doesn't matter what dose is, it's going to depend on the liver, and most of the time you'll be able to metabolize it. You don't get the surprise from the fat. Add to that, if sedation holiday, if you add to it that you wake the patient up and tell him, hey, you're in whatever, and you're doing great, and you had a car accident, you're improving, whatever. If you tell him that's orientation. You keep telling him that twice a day or once a day, every time you wake him up, then he's oriented. If you allow him to move a little bit during the sedation holiday, that's myopathy. And if you combine it with SBT, which is the spontaneous breathing trial, you're taking the pressure from all that high pressure on the vent and going down to 7/5, very low pressure, which means that the secretions will spew out of the patient, because you're decreasing the positive pressure. Secretion will come out, and it's a nurse will suction to the pulmonary toilet, right? So that's all of these advantages for the sedation holiday. I'm gonna say number 2, and then I'm gonna tell you a couple of few things that we learned from experience from these two. Number 2 is that let's say the patient cannot have the sedation holiday, right? So there are certain contraindications. For example, open eye. You're waiting for the ophthalmologist to come and repair it, and the eye is open. Don't do sedation because he's gonna pop his eyes. The vitreous is gonna be on the eye is gonna be here. Huh? The open abdomen sometimes, we're getting a little bit liberal with that. Rapid AFib, if the patient is having 120 heart rate, what do you expect the heart rate to be when you wake him up? Don't wake him up. Don't test that. That's a bad test to do. Uncontrolled CAD, like somebody's having an MI, it's cooling off from the MI. He didn't have a stent or anything. He's having an MI and lower, so don't wake him up. He's gonna have another MI, from the stress, and also increase the ICP or potential for increased ICP. You don't want the patient to. So if you have all of these things, the only thing you can do is to decrease by 20% the sedation every day. And by decreasing if this is 10 and you go down to 8, for example, the brain is not going to see the 8 right away. It's going to seep from here would be 9.2, for example, 9.2, 9.2. So the brain is going to see 9.2, so a little bit more easier sedation. We've seen so many disasters of applying these two, and if you don't pay attention and work with your nurses and work with the staff about how to do this stuff, then you're not doing sedation holiday. And I've seen these examples in other places where the sedation holiday is not done correctly. For example, I'll give you 6, 8 things, I don't remember, but fallacies or problems, okay? So number 1, which happens 100% of the time, the nurse will come to you and say, you'll say, did you wake the patient up? Be careful of what you're asking, by the way. Did you wake the patient up? She'll say, oh yeah, he's awake, he woke up. So you think, okay, he woke up. We're not interested in waking the patient up. We're interested in stopping the sedation so it doesn't go to the fat. Waking the patient up, I don't care. I mean, it's great, but that's not the purpose of the sedation holiday, right? So when you tell the nurse, take the patient off the Versal, she says, but he's awake. He's responding on the Versal. He's saying, yes, I have pain or no pain. He's writing even on the thing, yes, the Versal is running at 5, but he's responding. Still, I want to stop the Versal so I can get the Versal off the fat. And then we can do whatever we want, right? So it has to be completely off. That's number 1. There's no I'm decreasing it until he wakes up. It has to be completely off. And I'll tell you a couple of things. I've seen it in at least 2 cases that I've seen myself, but I bet you if I'm outside more, I'll see more, right? A couple of times the nurse says, I don't want to wake the patient up now. Oh, I'm busy with the other patient, blah, blah, blah. Can I wait a little bit longer? Please, but he's awake. If I stop the sedation, it's very light. If I stop it, he's going to wake up right away. And then she stops the sedation, and the patient takes 12 hours to wake up. The one that was light, that was talking to us. Why? Because this is a ratic pump. This pump doesn't have a rate, the one that comes from the fat. It depends on a lot of things, blood flow, fever, anything will just bring a bolus of Versed into the blood if the blood concentration goes down to 0. Who knows? Right? So we can't control it. So we have to be careful. This is like really what shoots you in the foot all the time, right? Number two, we found okay. So some nurses will stop the sedation, and let's say the patient is running at 10 of Versed, and then say the patient is supposed to wake up at some point. 2 hours, I say at the max. Usually if it's more than 2 hours, there's something wrong, right? And the patient takes 12 hours to wake up. Huh? So the nurse waited until the patient woke up, and the SBT, whatever, the patient failed the SBT. She wants to put him back on the vent, so she put him on what? On 10. No, if the patient already, the patient told you that he has already, that this dose is too much for them. It started to accumulate already. Then if this happens, if the patient takes more than 2 hours to wake up, then you start the patient on half what he was on before, right? Number three is there is a misconception that the SAT and the SBT has to happen together. So for example, they turn off the sedation and they call respiratory to put the patient on SBT. So what happens is that the patient is not completely awake yet. By the way, I'm not, this is number, like, I'm going to say number X here, which is, this is idiotic, and this is idiots. Huh? Yeah. Huh?
It's too low.
Yeah.
I can't see it.
Idiots. This is idiots. Huh? Huh? So basically, it doesn't happen here. So that's why I don't want to talk about it too much. Is people actually who do SBT on sedation. And a lot of those people are the same people who use analogous sedation, by the way. Not all of them, some. Because what happened is that they're like confusing the concepts from surgical ICU and medical ICU. The surgical ICU, because the patient is having pain and we have to be humane, right? So when we wake up, so the patient goes on Versed drip and fentanyl drip, for example, right? If you want to wake up the patient for SBT, you don't stop the fentanyl drip. That's the pain. You don't want him to have pain. So you stop the Versed and wake him up on fentanyl drip and extubate him on fentanyl drip. That's the surgical ICU. Somehow there's a confusion, and they do the same for the medical ICU too. So they just like lower the fentanyl drip a little bit and wait for the patient to wake up, and they never come off the sedation completely, and they do the SBT on sedation. That's wrong. It's been proven. Studies show that it actually makes you fail the SBT because respiratory depression. So we don't even need to bring it up here. Okay. So for the nurses that actually do the right thing and stop the sedation and call the respiratory therapist is going to come in and put the vent on 7/5. The patient now is tachypnic. Within a half hour, is very tachypnic and he needs to go back on the vent. So they put him back on the vent and put him back on the sedation. Did we see the light of his eyes? Did he open his eyes? No. Right? So what we decided, and we tell the nurses that you have to finish the SAT before you move on to the SBT. You have to complete the SAT. You have to be completely awake before you move on to the SBT. Right? And next number is what's awake? What's awake? Even that we're disagreeing on. Some nurses, awake meaning, oh, he's reaching for the tube. That's not awake. They reach for the tube all the time. They reach for the tube every day, So even when they're deeply sedated. So reaching for the tube is not meaning awake. Awake meaning obeying commands or trying to obey commands. Open your eyes. Okay. Yeah, maybe he's trying. He took the information, he processed it, and then he actually had some motor action based on it. Doesn't have to be completely awake answering math questions, for example, right? So that's that. And doesn't have to really pull his head off you're just asking for too much if you ask him to pull your head off because it's too much and they're painful and the tube is hurting and stuff like that. So I don't do it usually. All right. So that's the how awake the patient is. We decided that. Also, we know that these medications accumulate, Versed and all this accumulates, right? So you can't be on the same dose on the second day. So if you're on the second day, we were telling the nurses, is that if you find yourself on escalating doses of Versed on the second day of intubation, there's something wrong. Go to the residence and they're probably going to give you vitamin S, Seroquel, or something like this. right? Seroquel has been proven, by the way, it's been studied and showed that decreases the use for sedation on events, right? So that's important. The last one is on the third day. That's the second day. On the third day, if you find yourself on more than 50% of what the original dose was, there's something wrong, because you should be on more than, less than 50% from that. Then also ask for something else. Maybe one of those circles that we wrote before is not satisfying. Okay, so that's your fallacies and things that can happen with the SAT and the decrease by 20% and everything. Okay, number 3 way of doing that is actually bolus and drip. So I told you before that in 2006 somebody came up with a study that rats and they showed the diaphragm is weak and stuff like that. 2 days of ventilation. So that's the bolus drips came and became very. But that's always happened in the literature, especially in the ICU. We have when I was young, it used to be the majority of studies were going in the direction of sleep in the ICU, and so a lot of people were having. I was of the opinion is that people we're not able to wean the patients, or not successful in weaning because the patients don't have enough sleep. So we have to zonk the patient and not even wake him up at all for 10 days until he's ready, and then we try to wake him up. Then that was extreme, right, and bad. But then we moved all the way to the other side of the pendulum, which is really horrible, which is bolus sedation. So I went to a lecture where the lecturer, big keynote address, and the lecturer was saying, "Keep them awake." The title of the lecture, and I was so mad. I had to leave early, because what do you mean keep them awake? Imagine, because we discovered that we are doing a bad job with the sedation as physicians, we're now going to inflict it on the patient and say we're going to keep you awake, because we can't do it anymore. There's a group in Hong Kong actually that took this a little bit further, and actually said no sedation versus bolus sedation. You put the tube inside somebody's mouth and not sedate him at all, just tie him down, and do the whole care for 2, 3, 5 days, whatever needed, and then take the tube out. And the result of the study, they actually extubated early. Yes, of course. Yes, of course they extubated early. Because if I'm the patient, it's like, please, take the tube out, please. I'll behave, I'll breathe, I beg you. It's crazy. So they take it all the way further. It's similar to, imagine if you go to the dentist, for example, and you go to, and you go to it's painful. The dentist, I hate the dentist, but in general, you want to have your tooth removed. So you're expecting some dignity at least. You're not going to be screaming like a child in the thing, right? And you go to the dentist and say, "Oh, haven't you heard? Novocaine decreases healing or decreases receptor or bullshit, anything like this. I'm not going to give you Novocaine. Just tough it up. It's only 2 minutes." I'll take the first instrument, put it in the dentist's eye, and run. So same thing. Why are we keeping patients awake? That's wrong. So somebody, I wish I was that person, but somebody made a compromise. He said, the pendulum going like this, we're gonna stay in the middle, which is bolus and drip, and I think it's amazing. Why? So basically, what he does a drip like this, low dose drip, and bolus is for breakthrough on top of it. And this is not foreign to medicine. We do that all the time, right? Lantus and Lis, OxyContin and oxycodone. You always do that, right? So to decrease the peaks and valley. But in the ICUs, even makes more sense, right? So let's say a nurse is having a patient on 10 milligram of Versed, and she's turning him to clean his back or something like this. When she turned him, he's like jumping, fighting and stuff like that, right? So she goes from 10 to 15. How long does it take for the patient to feel the 15 in his brain? 4 times the half-life. That applies to any drip. Levofed, 2-minute half-life. If you go from one dose to another, you're not going to see the effective dose for 8 minutes. Nitro, 1 minute. Nitroprusside, smaller. All of these things. Fentanyl, if we say, 20 minutes half-life, then, Versed, half an hour half-life, or duration of action is a half hour. I'll be generous and say 2 hours. So this patient is going to feel the 15 that the nurse went from 10 to 15 in 2 hours. Imagine that. So of course she doesn't know that. She goes to 15 and keeps, the patient keeps on jumping. So she goes through 20. And by the time she goes to 20, she's done with what she's doing. She put the patient back, and the patient's like no stimulation, so he sleeps. So she thinks that the 20 is the dose that puts this patient to sleep, until the next nurse, never go below 20 because he's gonna jump off the bed, right? And that's where we get all of these high doses because, of stuff like that. So the bolus and drip resolve this issue. They actually give a drip, and then if the patient, there's something that you're gonna do, like you're gonna advance the endotracheal tube, you're gonna do something to him, then you give him the bolus and keep the drip the same. And even we went a little bit further, because the nurses, even with the order for the bolus, it's easier for them to go up on the pump in the room. They don't want to go to the Omnicell, so we actually made it on the pump. So they have a button on the pump that says bolus, so they give a bolus. That made it very easy for them to do. All right, number 4, and this is my invention. You're not gonna find literature about it. It's called propofol sandwich technique. There was a propofol sandwich technique in anesthesia, but it was for a different technique. It was actually to prevent nausea and vomiting, and failed, right? But this propofol sandwich technique needs a study. So whoever is going to do critical care needs to take this and fly with it, because I can't do it here because we're already doing it for years. And this makes all of the sedation foolproof. You can wake the patient whenever you want them to wake up, right? And all that we're asking is to give propofol. That's the first, bread. Let's say in the first few hours, the first day, and then you find that the patient is hypotensive, for example, or have high triglycerides, or you don't have propofol in the hospital or something like this, then you give him the Versed, for example, for 10 days, right? All that we're asking is the last day before you think, just anticipate, say tomorrow looks like he's going to be extubated or something. Stop the Versed and put him back on propofol for 1 day. During this 1 day, it's more than enough for the Versed to come off the body and the fat completely. And then the propofol, 10 minutes, you wake the patient up. So you land in JFK, anywhere you want. You're just like a helicopter. You hang anywhere you want, right? And I do this bread here is a little bit longer sometimes. Once the patient doesn't need to be on Versed, why put them on Versed? Once the blood pressure is high, put them on propofol, it'll be easier. If the patient never was hypotensive, I don't use Versed at all. I use propofol, and makes the sedation also very, very easy, right? It's too good to be true. A lot of people don't like to. When I say it to people, it's like, it can't be that easy, but it's very easy actually.
You if their hemodynamics are concerning, you just put them on Levofed for that.
Oh yeah, yes, for that last part. But it would be crazy for me to do that if they are like that tenuous to extubate them. So. But if that's the case, if I can't extubate them other than this technique, then I'll put them on a little bit of Levofed. And what we do is that we combine the 4 things together. So in your order set, you'll see the 4 things are there, actually, presented somehow. And that is it. All right, we're done, professors. Any